Hyperactivation of the immune response, including release of pro-inflammatory cytokines, might play a key role in pathophysiology of severe illness from COVID-19. The safety and efficacy of anti-interleukin 6 receptor antibody, Tocilizumab, in patients who are hospitalized with COVID-19 pneumonia are unclear. To discuss all this, I, Dr. Bharat Jagyasi, have Dr. Farhad Kapadia with me. Dr. Farhad Kapadia is Consultant Critical Care, Hinduja Hospital, Mahim. He is also past President of Indian Society of Critical Care Medicine. Dr. Farhad Kapadia, welcome to podcast ISCCM.
Thank you for having me.
So my first question to you is, it's a major question altogether. Should we be using Tocilizumab? Is it going to be of use? I mean, there's been lots of commotion around this use. So what is your take on it?
Well, my honest take is I can't understand what the commotion is about. There is a very large trial which has categorically shown a improvement in mortality. So I really don't understand why there should be any confusion. But if we take a step back and if you'd asked me in the beginning of the pandemic, would I consider using steroids or Tocilizumab in such patients with severe pneumonia and multi-organ failure? I've said no to both. Because the previous experience, there was nothing in Tocilizumab in sepsis and pneumonia, and steroids were really very, very plus minus in pneumonia. Having said that, ultimately what you think and what you believe and what you practice is less important than what outcome data and good trials shows. And when the recovery clearly showed a benefit, a significant benefit, a reduction of about mortality risk ratio about 0.8 or so, I could see no reason not to use it. Because regardless of whatever my background theory of steroids were, my likes or dislikes, biases against it or for it, here we have data from 2,000 odd patients saying that you can decrease the mortality by using it. And when you choose to use steroids in this context, you should just follow what the criteria used by the trial. So recovery happened to use it in all comers, but found the benefit in those on oxygen and those on ventilator. They used 6 milligrams of dexamethasone, and they used it for 10 days, stopped early if the patient was discharged. So that's the way I used it. Now, to come to your Tocilizumab question, I follow exactly the same philosophy. One could do a lot of background research on how it's used and why it's used. But what we have is a very large trial. In fact, we have 2 large trials. But even after REMAP-CAP came, I found it very difficult to understand those statistics. So while I changed my mind that I might use it, I didn't really get around to using it. But with recovery coming in, we have a sort of 4,000, 5,000 patient trial with a magnitude of mortality reduction almost identical to the steroids, with pretty equally robust statistics. It was clear to me that not to use it would be to deny the patient a life-saving intervention. And to be clear, if you leave aside basic intensive care like oxygen and fluid resuscitation, there are only 2 things which have been demonstrated categorically to improve mortality and severity in COVID, and that is steroids and Tocilizumab. So I can really see no reason not to use it as long as you use it in the same way as the recovery investigators used it. In fact, I would take it one step further. I think even if you don't believe in it, it's your almost ethical duty to inform the patient that there's such a life-saving option available, and they need to know that there's a potential of using it, even if you don't believe it works.
So I said you took me to my next question, where you said we should be using it the way recovery use it. So what is that way? I mean, when should I use it, and how do I time it?
Okay. So recovery, again, luckily for us, was very clear. Those who were on oxygen and those who were ventilated benefited. So it's really pretty straightforward. Yeah. They happen to also be measuring CRPs on everyone. And if the CRP was more than 75, so it makes sense to measure because it's an anti-inflammatory drug. You got to show that there is some inflammation going on. If by chance the hypoxemia is due to a non-inflammatory component, it doesn't make sense to use it. Since they didn't measure IL-6, you could possibly just say someone with a high CRP requiring oxygen is an appropriate candidate for Tocilizumab, as long as you believe the hypoxemia is due to the disease, not some confounding factor. So that would really be the indication. A person on oxygen, now maybe it's 1 liter, 2 liters.
Yeah.
But again, if you choose to follow the trial, people on oxygen have a lower chance of dying if you give them Tocilizumab. If their CRP is high. How you want to spin that is up to you, but that's the ground reality which 4,000 odd patients have told the medical community that if you give it to us at such and such point of time, many more survive. So
recovery
indication in 2 lines is needing oxygen and a high CRP.
So, I mean, then there's no cutoff. Then there would be too many of patients around. So what do you practice in the clinical scenario, sir? I mean, I know the recovery says...
Almost all these patients will anyway be on oxygen. Almost all these patients will. So I give as soon as someone meets these criteria, I inform the family that we have the option of using this. And if we get the go-ahead, we use it.
So someone who's
and really we ask them because of the cost implication.
So someone who's just around 4 to 6 liters of oxygen, you will give that option, sir?
Yep, sure. Because the reality is, unfortunately, this is the unfortunate reality, is that we have no way to know where that patient will be 2 days or 3 days down the line. Now, I think if you're asking me that someone was on 15 liters and then came down to 10 liters and then came down to 4 liters and then came to my ICU, I probably wouldn't use it. But then no one like that is actually coming to ICU. They're coming into ICU because they're getting worse, not because they're getting better. So if someone is getting worse and beginning to require oxygen, that would be the time to use it, because that's the time it was successful in recovery. Having said that, it was even more successful in those requiring ventilation. So the more sick the patient is, the greater the mortality reduction.
Yeah, so
the greater the length of stay reduction.
That only. So what about the patients who comes on 100% NIV and who are already ventilated? Because I believe those are already fired lungs and the damage has been done. So do we have...
They're inflamed lungs. Why do you say they're fired lungs? They're inflamed lungs.
They're inflamed lungs. Correct, yeah.
Right.
So but the damage has been done?
No, it's the damage is ongoing and you're going to modulate it. The damage is done is when you have fibrosis.
Understood.
Okay, so there is an ongoing inflammation, and that ongoing inflammation is adding to the lung injury and is adding to the gas exchange problem. And if you can modulate it in a way in which the benefit outweighs the harm, then that's a sensible thing to do. And therefore, the recovery has shown that in this group of patients with active inflammation in the lung, modulating it with this particular dose of tocilizumab, ultimately the good outweighs the bad.
So, in fact, as you said, the higher the damage, it was more beneficial in those kind of patients.
The higher the severity of oxygen need. In other words, the non-oxygen patients didn't benefit, the oxygen patients benefited, and the ventilated patients benefited more.
Understood.
I'm not sure about the non-oxygenate patients, so I'll have to counter-check that.
Okay. Sir, I mean, it's been known to be an immunomodulator, as you said, and there have been high incidence of sepsis all throughout, and for the major reasons, tocilizumab is also being blamed for that. So, do we have to rule out the sepsis or rule out other things before I consider I have to go ahead with the tocilizumab? You do something.
But again, if you're going, I'm assuming that we're going to use steroids in these patients. And whenever we start steroids, we would do some sort of a septic screen, right? Someone who's got a bacteremia and who's rip-roaring bacteremia, we'd probably say this is not a patient. So in exactly the same way, if they're not in an obvious frank clinical sepsis, and you feel that the patient is an appropriate patient for steroids, then the patient is an appropriate patient for tocilizumab. Or if there's a rip-roaring sepsis, you control the sepsis and then take it from there. But if there is some question, of course, if there's active TB and if there's, active fungal infections, then you won't use steroids and you won't use tocilizumab. But if you have your standard COVID patient who's generally mostly okay and now has got a new infection and now is getting more and more breathless and the lungs are getting worse and there is no other out of control infection, and that's the phase they really come to you, right? They don't come to you with TB cavities or mucormycosis or stuff like that. They don't come to us in that phase. So that phase you should use it. I mean, I sort of half cynically say most people would prefer to be alive after 28 days with an opportunistic infection than dead before 20 days without an opportunistic infection. So you've got to keep the big picture in mind. I mean, we definitely need 60-day outcome data. We definitely need 6 months, 1 year outcome data. And if that data is shown to be very harmful, we'll change our practice at that point of time. But at this point of time, with such a big mortality benefit, I can't honestly see a reason not to use it. And even if you don't believe it, not to at least offer it to a patient. To not offer it to a patient because you're skeptic, in my view, is not a good way to practice medicine. I just like to add 2 more things. The early trials were negative primarily because they were used early.
Okay, sir.
Okay, so the mortality in those trials was like 3 to 4%. So it was used to prevent progression to ICU, to oxygen. It's not to be used in that context.
Understood.
And second is the meta-analysis which was given along with the recovery paper showed that recovery had more patients than everything else put together. So clearly the recovery data is as of now the most important data in the tocilizumab.
Thank you, sir. Thanks for the message. Thanks a lot.
Okay, congratulations for the good work you're doing for ISCCM.
Thank you, sir.
Okay.
Thank you. I mean, you cleared too many questions around. Thank you for doing this for me. It's always nice talking to you. Thanks, Dr. Farhad.
That's all for now. Thanks for listening. See you again.